Thank you for the introduction, and thanks again for organizer for inviting me here. So I'm going to address the topic of HALT and HAM after TAVR. So just to first, let's agree on some definitions. So we are talking about subclinical leaflet thrombosis, SLT, that can be actually HALT, hypoattenuated leaflet thickening. So we have the thickening of the leaflet. So, and this is something we're going to see on CT scan, actually. These are images that we can see that are not necessarily associated with any dysfunction of the valve. And when we start talking about leaflet thickening that is restricting the valve motion, here we are talking about HAM, so it's hypoattenuation affecting motion. So we have three definitions that we need to agree upon because it's not the same impact. So we have in classification, if we look at this classification from 2020, it's going all the way from grade 0, where we have no thickening, to the grade 4, when it's more than 75% of leaflet thickening. And you can see in the sketch on the right of the image, the blue part, which is actually the thickening of the valve. And of course, the more we are getting to a higher grade of HALT, we are getting close to HAM, and we will see restriction that might start with grade 1, and of course, it will be there when we go to a grade 4. This is almost immobile valves. So how to predict SLT in reality? So there are several predictors that we know about. We know that male sex can be a part of it, large body mass index, large sinus of Valsalva, bicuspid aortic valves, the hypercoagulable states, these are patient-specific. There's also device-specific, intra-annular valve, larger internal diameter, and balloon expandable. And we also have procedural-related, so absence of anticoagulant, valve-in-valve, patient prosthesis mismatch, and under expansion. So I'm going to develop some of these points, but those are in general what we need to take a look at to predict HALT. So the valve type, if you look at this meta-analysis that was performed in 2021 that included more than 50 different studies, we see that obviously intra-annular versus supra-annular valves, there's an increased risk when we are working on intra-annular valves, and the relative risk is almost twice. So if we go specifically to Edwards, if we name it Edwards versus Medtronic, then we see that obviously with Edwards we'll see more HALT in those patients, SLT all over. It's not necessarily HALT. If we look at Evolute low risk patients, and we've seen that with Evolute low risk, I don't know if you remember how Evolute gave an excellent result, better even than surgery in those patients, but we see that the HALT, where there was no difference between TAVR and SAVR in this regard, and it wasn't correlated with valve hemodynamics or clinical outcome. At the opposite, we know that partners gave a similar result, partner 3 gave a similar result between TAVI and surgery. Here we saw that with TAVR, and this time it's the Edwards valve, it's an intra-annular valve, and it's a balloon expandable. Here there was a little bit more HALT in the TAVR group. But this wasn't associated with big event, even though there was a minimal increase on transgradient valvular gradient. So what happens actually when we have an intra-annular valve? When we have an intra-annular valve, we have the larger in neosinus, and we consider that probably there will be a stagnation in this part, and this is maybe a reason why we will see more HALT happening in those patients. Again, it's similar to what we are doing with coronaries. We now understand the importance of really expanding the TAVI valves when we implant them. And again, we know that if the valve is not fully expanded or if it's asymmetrically expanded, here the deformation is going to be a predictor of the occurrence of HALT. Antithrombotic therapy, we know that today the guidelines are asking it actually to go for single antiplatelet therapy. But if we look at this meta-analysis of pooled information regarding anticoagulants or not, we see that actually with anticoagulant, the incidence is much lower. It's almost 3 times lower than with DAPT or SAPT. So obviously, antithrombotic therapy is protective. Another thing we can see is actually if we think that maybe let's try whether DAPT is better than SAPT, actually no, whether it is 2 antiplatelets or 1, it's not going to make any difference in terms of HALT. What is really playing a role is the presence of anticoagulants. So what's the impact of SLT? There is an increased risk of stroke. I didn't go through individual studies because we have this meta-analysis that actually was pretty inclusive, and we see that there is more stroke or TIA in patients who will develop HALT. So there's another thing that we need to worry about is the potential for valve thrombosis, because we will start with some leaflet thrombosis, initially subclinical, but we might, not all the patients will get to this point, we might get to clinical leaflet thrombosis and severe valve thrombosis. So this is one risk we are taking, the risk of severe thrombosis. And the other risk is that we are taking, and the more we are treating low risk and younger patients, the more we are worried about the durability of the valve. We know that the thrombus and the pannus that we are seeing initially will lead to undetalization, to inflammation, fibrosis, and eventually to calcification. So this bed of thrombus that we are seeing at the base of the leaflets can be the primum that will lead us at the end to earlier valve degeneration. So these are mechanisms that we might worry about. So what about the role of treatment? Again, we've seen that oral anticoagulants had a protective effect, but what happens if we already seen the HALT and if we put anticoagulants? Here we can see that actually if we put anticoagulants, then we will have much more frequently thrombus resolution than if we just remain with the usual treatment. So actually that effect is 5.35. It's an important effect that we have with in terms of reduction. Also in terms of stroke and TIA, another thing we were worried about, obviously there's interest in the thrombus resolution in those patients. So technically, what is recommended today? So we remain with the usual scheme. If we start with, if we do the procedure, we will look at whether the patient has an indication for oral anticoagulants or not. If they have an indication for oral anticoagulants, if they had a recent PCI, then we will go for antiplatelet therapy at the same time for 1 to 6 months after the treatment and then after the PCI, and then continue with oral anticoagulants alone. Otherwise, we will just stick to oral anticoagulants. Now, if there is no indication for oral anticoagulants, then if there is no recent PCI, it will only be a single antiplatelet. There's no real recommendation so far to oral anticoagulants. But if they had a recent PCI, only in that case, we'll go for dual antiplatelet, at least for 1 to 6 months, and then continue with single antiplatelet. So this is not changing. What needs to change is what happens when we see the subclinical leaflet thrombosis. Of course, I'm not talking about a patient who has a thrombosis of the valve, patent thrombosis with symptoms. I'm talking about the asymptomatic patient, elevated gradient maybe on TTE, and the HALT that is confirmed on cardiac CT. In this case, we can go for oral anticoagulant for 3 to 6 months. For ease of use, we might go for new anticoagulants, oral anticoagulants, but we can also go for Coumadin, and then we can repeat the CT. So we have two possibilities. Either we have the resolution of the HALT, and in this case, we have to discuss still we don't know when to stop actually the oral anticoagulation, but we might consider keeping it if it's well tolerated by the patient. In the other case, if we are still persisting with anticoagulants, then in that case, with the HALT, in that case, if we're using Coumadin, then maybe we will consider increasing the target INR to 2.5 to 3.5, or we can switch oral anticoagulants and go to Coumadin if we had started with oral anticoagulants. So in conclusion, if we want to summarize what are the real risk factors for HALT, the reality is that intra-annular valves are associated are the major predictors. SLT, after it has happened, can lead to stroke and TIA and potentially valve degeneration. Oral anticoagulants can reduce the risk of its occurrence, but also once it has occurred, it can lead to SLT resolution. But we have remaining questions. Most of those HALTs are actually asymptomatic. So the question is, should we follow up the patients with regular CTs? And also the other question is, what's regular? How many times do we need to perform CT on our patients for follow-up? All these are questions that we still need to address. Thank you for your attention.